In the last 2 years, we have seen a couple of new data in patients with pre-treated non-small cell lung cancer. And we have got a lot of information, but we also have seen some problems with the new agents in these quite new trials. Nivolumab has been investigated in a large trial, Checkmate 57, compared head-to-head to docetaxel. We have seen a significant improvement in overall survival, and this has led to the approval of nivolumab in this group of patients. However, we have to be aware that nivolumab has not been tested to the most efficacious second-line combination which is available, and this is either a combination of docetaxel and nintedanib or docetaxel and ramucirumab. And furthermore, we have seen that there has been a crossing in the overall survival curves, which means that indeed there have been some patients not really benefiting from this treatment with nivolumab. On the other hand, the antiangiogenic compound nintedanib has been investigated in a rather large trial, the LUME-LUNG-1 trial, in combination with docetaxel compared to docetaxel alone in pre-treated patients with advanced non-small cell lung cancer. We have seen a significant improvement in progression-free survival, and this has been the primary endpoint. And we also have seen a significant improvement in adenocarcinoma patients, prolonging the overall survival in favor of the combination. Something which has become very interestingly, in particular in this group of patients with adenocarcinoma, has been the observation that this combination has a pronounced efficacy in poor prognosis patients with pre-treated adenocarcinoma, and these are patients with fast progressing tumors, and these are patients who never responded to first-line chemotherapy, who had progressive disease as best response following first-line chemotherapy. And these are factors that we have to outweigh when we make our selection between the combination of docetaxel and an antiangiogenic compound and immunotherapy.
In patients with rapidly progressing disease in the second-line setting, options include immunotherapy and docetaxel, potentially with nintedanib. The LUME-1 study has demonstrated preferential activity of docetaxel in combination with nintedanib in patients with adenocarcinoma, in patients whose disease has either relapsed within 9 months of commencing first-line treatment or that has progressed as best response of first-line therapy. So for these patients with rapidly progressive disease, combination docetaxel-nintedanib could be an alternative regime for them and seems to be better than docetaxel monotherapy. We don't seem to have this data the same way for combination docetaxel and ramucirumab. In terms of immunotherapy, we know that with nivolumab, the extent of benefit of nivolumab is very much contingent on the PD-L1 status. And in patients with either low PD-L1 status or tumours that are rapidly progressive or patients that are becoming frail, that the benefit of immunotherapy such as nivolumab may be minimal. And for those patients, cytotoxic-based chemotherapy with docetaxel, with the addition of perhaps nintedanib, may be an optimal strategy.
In the recent trials that has been published for second-line treatment of patients with advanced non-small cell lung cancer, in particular in those trials investigating the efficacy of antiangiogenic agents in combination with chemotherapy, we have seen that there is a pronounced efficacy of these combinations in patients with fast-growing tumors. And this is something new. We haven't seen this before, and we haven't assessed this before. But now, in my clinical practice, I check the career of my patients with regard of the interval between the time of the first diagnosis, the time of relapse, whether I can get some flavor whether this is a fast-growing tumor, yes or not. And indeed, this characteristicum, this does impact my decision on my treatment selection.
I think one thing that we've become aware of is that the interval from first to second line treatment actually tells us something about the biology of the cancer. So when selecting a second line treatment for a patient, a short interval indicates aggressive nature of the tumor. It probably also indicates that this particular tumor is dependent on neovasculature. So the addition of anti-angiogenic treatment makes more sense in tumors that are progressing rapidly. And for that reason, I think it's important to look at this particular factor when selecting a treatment. And we see different outcomes when we look at recent trials. For example, we see with anti-angiogenic agents such as ramucirumab or nintedanib that the shorter the interval, the bigger the effect. But we see the reverse when we look at the checkpoint inhibitors, where apparently if there is a good long interval from first to second line, the benefit from immune therapy is bigger.